Hello everyone, this is Sewaillem Material. I'd like to share with you a step-by-step approach for a type 3 large hiatus hernia repair with the mesh and fundoplication. This is a 55-year-old male who's complaining of shortness of breath, which he thought it was due to his heavy smoking. Recently, he became more dyspneic, and an X-ray showed a radiolucency retrocardiac. This was followed by CT, and you can appreciate this type 3 complete stomach herniation into the left pleural cavity with a wide neck and omentum as well. Almost the whole stomach is slightly twisted. There was no symptoms of dysphagia or recurrent vomiting. So he was worked up and was prepared for a laparoscopic hiatus hernia repair. His workup also included a gallstones with a thick wall, and the first part of the surgery was a laparoscopic cholecystectomy, which was not narrated in this video. Once we're in and attention was directed to the hiatus hernia, we can appreciate this large defect. No adhesions in the sac, and the stomach was completely pulled back and freed from the collection. We usually take a look to see how big is the defect, how thick is the sac, and so forth. So show the large sac just comparable to the finding of the CT. You can appreciate in the lung and the pleura behind this huge sac, which will be dissected out first of all. So our approach for this hernias and any other hiatus hernia, first of all, we identify the edge of the herniated sac, and we dissect near the right or left crus. And then with the gas insufflation, the planes between the sac and the defect becomes obvious, and you can easily pull out the sac. So we're seeing the herniated sac first, and we're just pulling apart the sac and releasing it from its cavity. We direct our attention now to the right side, and we take down the false placenta condensa to expose the right crus, and also start our dissection on that side as well. And we'll meet in the middle. We go on the right crus and the left crus, like I mentioned, and this will help expose the edge of the sac. Then we complete our dissection just at 12 o'clock. Like I mentioned, now we're going to connect both choroidal dissection in the middle and just pull on the sac as we can. Most of the difficulty in finding the sacs is at the junction between the choroida and the sac. Once you find the plane, the rest are easy, and bringing the sac out is really not that difficult once you're in the right plane. Now, the most technical part is the retrogastric sac, which you need to mobilize the stomach and the esophagus in order to go behind them and bring their sac and deliver it. The angle is a bit difficult and dissection is a bit tedious. And if you always lose your planes, might as well just go back from the beginning. We are now over the aorta and just dissecting the sac behind the stomach, pulling the stomach with us. Once we mobilize the sac from, let's say, 8 o'clock to 5 o'clock, and to get exposure of the posterior gastric space, we'll take down the gastrocolic ligament for two reasons. We can expose the retrogastric space easy from there, and just in preparation for fundoplication at the end. Now, in this area, you're confronted by the posterior gastric sac with the stomach through it. You're a bit of balsifaton posterior area and the short gastrics. Taking your time, finding your planes is the way to go. Once you release the sac from the lower end of the crus, you can mobilize more and more stomach easily. As you can see, the sac is now apparent. And we'll just take it with us. One way to not to lose where you're dissecting is just stay on top of the left crus. and dissection will be easier, and your planes will be obvious as you dissect more. And mobilize the sac from the left crus. Now we have a good exposure of the retrogastric hernia sac, and we're just mobilizing it. And like I mentioned previously, once you're in the right planes, the rest is easy. Pulling the sac and dissecting it from its cavity is also not that difficult. The problem is finding the planes between the sac, the fat, and the stomachs. This patient's BMI is around 31, but we witness the amount of mediastinal and visceral fat here and there. Now I have the stomach and sac and esophagus all together, and I'm working on the posterior to the sac. Now I go back from dissecting 6 o'clock to 5 o'clock and showing the rest of the sac as I pull out. And like I mentioned, once you're in the right plane, it's easy. Now I have the sac with the stomach and esophagus in it, and this bleeding is from the posterior mediastinum small vessels. And just to get exposure more, we're dissecting now from 6 o'clock to 8 o'clock position on the hiatus, just to get the sac on the other side and connect the dots. Now just finishing some bands in between the sac and posterior mediastinum. One way to expedite easy dissection is to loop the esophagus, and this is our target going behind the retroesophageal window and making a space for us so we can loop the esophagus. This will help in dissecting more esophagus without injury to nearby structures. We're working on the right side of the esophagus. Vagus is next to the esophagus, and we're a bit on the more lateral. You can see the pleura at 9 o'clock as well as the aorta coming by as we continue our dissection. Another plane that is safe to work is on top of the aorta, away from the esophagus and vagi. And the plane is usually a non-adherent area, and dissection is a bit easy in this place as you dissect more and show the esophagus. Now we're almost finishing our window. We're gonna go from the other side and connect the dots so we can loop it later on. So we're now on the left side of the esophagus, and we're dissecting small bands and adhesions in that area to expose a retroesophageal view. And that was done. And we'll just loop it with a ribbon gauze. We put a ribbon gauze on the one window and deliver from the other side. Once we loop the esophagus and deliver it more anterior, we can dissect with ease the retroesophageal and retrogastric bands and adhesions, and open both windows to mobilize more of the esophagus and stomach. You can appreciate the vagus near the esophagus, and like I mentioned, we're dissecting just on top of the aorta, making it easy to expose this plane. It's always an avascular plane, and small perforators are seen and controlled. Sometimes you can find the pleura, you can sweep it off, and if you have an inadvertent pleural injury leading to pneumothorax, it's not that big of a deal. You just communicate with your anesthesiologist, so he will know that the air pressure is a bit high or the patient desats, and you can control your surgery later on with these maneuvers by increasing the FiO2. Now we're dissecting the anterior cervical esophagus, retrocardiac space. This is also an avascular plane as long as you're in the right plane. I always like to dissect in big hernias or redo surgeries as high as possible to mobilize enough of an esophageal length. And for the unlikely finding of a short esophagus, it would be adherent after you mobilize enough esophagus. And finishing dissecting on the left side. You don't want to be too aggressive on this side. You may nip the right gastric as it's behind the esophagus from the right. You always want to communicate very well with your assistants, especially the cameraman. This is a narrow space where two instruments, camera, and a third instrument pulling the esophagus all in a narrow space. So good alignment of the instruments is crucial for a good view. It's been noticed in most of our cases, and that with large hiatus hernia and grade 3 or 4, you would find the pleura pushed more laterally, so the chances of pneumothorax in these type of hernia is rare, while the opposite is true for grade 1 type 1 hernia. Your pleura is just next to the esophagus, and if you dissect more laterally, you can induce pneumothorax. Now to complete the step, I like to take down the sac at the end. This is over the greater curve, and we excise the sacs without being too close to the stomach wall on the lateral edge, and definitely try to avoid dissecting the sac aggressively over the cardia. You may injure the left vagus when it curves anterior in front of the cardia. Final steps of taking down the sacs completely. I usually leave a rim over the cardia, and of course on the lesser curve. You don't want to be aggressive in dissecting the sac in that area. You may, like I mentioned, injure both nerves. The sac is pushed above the liver with the gallbladder specimen for later retrieval. And now we'll just take a final look and see how our dissection is. Like I mentioned, there's a bit of a sac on the lesser curve that I will leave it. Chance of injuring the vagus is high in that area. And just finalize some dissection to mobilize the cardia and more esophagus. So I like to sweep all the bands retrogastric, so I can mobilize more cardia and open a window for my wrap at the end, and expose the right crust from the left side. Find a few mobilization of the esophagus as much as I can. You cannot get enough mobilization. You can go as high as possible, and I've always considered this a very crucial part of anti-reflux surgery, mobilization as much as of esophagus as possible. Now we're ready for our cruroplasty. I use non-absorbable sutures, either nylon or ethibond, and I do a couple of interrupted, either simple suture or figure of 8, until I snug both crura to the esophagus. If the defect is big as this one, I want to add 1 or 2 more anterior sutures to complete your cruroplasty. And now we use another throw. You want to take the peritoneum on top of the crota, just not the muscles. This will avoid the tendency of probably tearing of the muscles without the peritoneum coverage. You don't want to be too tight, just snugging both crotas is enough. And a final anterior suture to complete our cruroplasty. After hemostasis, we utilize a phasic ST biodegradable mesh. There's many ways of applying the mesh. This is our technique. The rough surface is toward the diaphragm. Make sure you're not that close to the esophagus, and just apply fibrin glue, sutures, whatever you're comfortable with, to secure the mesh all around. And this is how we do it. Once that's completed, the final step is the fundoplication, and This patient didn't have a manometry, and considering his large hernia and probably chronicity, there may be an element of dysmotility. So we elected to do a posterior 270 toupet wrap. So our technique is 3 sutures, simple stitches on both sides of the wrap. The final one would be near or close to the GA junction. Of course, all the sutures used for anti-reflux surgery are non-absorbable. You can do one on each time, or all 3 on one end, and then start on the other side. As long as you do your surgery without any tension on the wrap or tearing on the esophageal wall. And our last stitch near the junction, like I mentioned. You can see most of the sac, the rest of the sac near the area, which I didn't like to bother removing because the vagus is nearby. Anyway, this is the end of the procedure. The patient actually did well. The barium meal post-op showed no reflux with a good flow. Thank you for watching.